Well, hello everyone. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane, and today I'm joined by my international colleague, Professor Tsutomu Takeuchi, who's Vice President at Keio University and Professor of Medicine in the Division of Rheumatology and Clinical Immunology at Keio University School of Medicine. Welcome back, Tom. It's great to have another discussion with you today. And the research paper we're going to be looking at today is one recently published in Modern Rheumatology, where Tom is the leading author. And it's looking at Upadacitinib monotherapy versus methotrexate monotherapy in methotrexate-naïve Japanese patients with rheumatoid arthritis. And it's a preliminary sub-analysis of the data. So I was going to ask you first, Tom, how has the whole COVID thing affected you and your patients, and how you've been treating your patients in the time of COVID? And what about vaccination in Japan?
Thank you very much for kind asking. At present time, the number of daily new cases of COVID-19 is coming down a little bit. Daily new cases in Japan is like 200 to 300. But 1 month before, that is going up to a 2,500 or 3,000 even. So the 1 month before, we are very much conscious about the rapid increase of COVID-19. That is the third peak. However, at present time, that is coming down by a quarantine or the not lockdown, but a soft lockdown in Japan. And as a result, the patient with rheumatic diseases are coming to a doctor's office regularly. We don't have much concerns about COVID-19 recently. However, the vaccination, speaking of vaccination, the Japanese government has a contract with some pharmaceutical company to import vaccine, but next week, we are starting a vaccination to a medical staff. So maybe the patients or the elderly population, the early April, they will start to receive vaccination. So the vaccination schedule is a little bit behind compared to the United States or United Kingdom or even China or Australia.
Okay. And you're going to have all the different vaccines available, or the Japanese government ordered just the AstraZeneca or the Pfizer?
Now the government is importing Pfizer vaccine, and they had a contract with AstraZeneca and Moderna also. And some Japanese pharmaceutical company has a license to produce vaccine from the Moderna or some other vaccine companies.
So it'll all happen. So it sounds good, and it's even better that the effect hasn't been too bad for you guys. So let's talk a bit about this study. Very interesting for a number of reasons, particularly because you've got the 7.5 milligram dose, which we don't have. Yeah. So can I just ask you what's happening with the JAKs in general in Japan? Has the TOFA oral surveillance press release affected things badly? And where does UPA sit in the prescribing in Japan as far as all the JAKs are concerned?
As it is always that the Japanese patient or Japanese physician are very much concerned about the safety signal, particularly for new drugs. So as a result, not only JAK inhibitor, but also biological agent, initially, they are very much concerned to start new drugs. So it is also true for tofacitinib, but for 7 years, post-marketing surveillance for all cases for tofacitinib users, we now know that the incidence of adverse events, so that is tolerable, and that is comparable to the biological agent, so that the perception is well understood. Not only for a rheumatologist and patients. However, the recent press release from the Pfizer shocked us because, as you know, there is some signal the positive signal for tofacitinib compared to anti-TNF for malignancy and MACE. In Japan, we also looked at some signal that is higher for tofacitinib compared to etanercept. But the patient population for tofa and the patient population for etanercept is quite different, so that we could not directly compare the population. So we could not draw the conclusion which is safer or which is much risk for particularly for malignancy and severe infection.
Sure. And you've got pefacitinib. You must have 4 JAKs or 5 JAKs available.
5 JAKs.
So and how are they doing in the market? Have they got significant market share? And how does UPA fit into that picture?
The new one is now going up. The tofa and then bari, followed by pefi and upa. The last 3 the filgotinib. And the baricitinib sales is going up, and followed by a upadacitinib maybe. The pefi is a local drug, so that the sales is a little bit slow. Basically the rate of a new drug is slow in Japan. Anyway.
Okay, so that's good. So let's talk about this trial. It's a population we're not allowed to treat methotrexate-naïve straight with the JAK. Is it the same in Japan? Do you have to fail some conventional methotrexates before you get to a JAK?
Yes, there is our guideline that the initial drug is a methotrexate or the conventional synthetic DMARD. If you fail to MTX or CS DMARD, then you can use the biological agent or JAK inhibitors.
Okay, so tell us a little bit about the SELECT early trial, please.
SELECT early, as you know, that this is the test, the upadacitinib and MTX in MTX naive population, basically. All of the patients are the MTX naive, but we can allow the 3 weekly doses of MTX. So as a result, 60–80% of the patients are used MTX, but no more than 3 weekly doses. That is a population, the basically MTX naive, to test the upadacitinib or MTX monotherapy, or monotherapy.
And in Japan, what is the rules again with methotrexate? I think it was just increased a little. What is the sort of top dose that you use?
Yes, as you know, the max top dose of MTX approved in Japan is only 60 milligram per week. So as a result, in this SELECT early trial, we are starting MTX 7.5 milligram per week, titrated up to 15 milligram per week.
Okay, excellent, thank you. So tell us a little bit about the primary endpoints and the secondary endpoints in this study, please.
Yes, particularly for PMDA definition of a primary endpoint, the ACR20 at week 12 and the change from the baseline of modified total sharp score at week 24. The both ACR20 and MTSS is a co-primary endpoint.
And the patient population, what were they like, the demographics at the baseline? Mostly seropositive, the duration of disease was not very long.
Yes, that's right. The seropositivity, yes. The inclusion criteria is required for the both rheumatoid factor and CCP, or more than one erosion on X-ray, plus a CRP, more than 0.5 milligram per deciliter. So that is the inclusion criteria. As a result, more than 80% of the patients had seropositive.
And about 45% are already on baseline steroids. And active disease, 16 swollen joints and mean HACs of 1.4. So they had active disease. So tell us what the differences between the groups on effect on your primary endpoint, please.
The primary endpoint is it's very clear that the Upadacitinib monotherapy is superior to MTX mono in terms of the ACR20 at week 12, and the change from baseline in MTSS at week 24 is very clear that that is very important. The change from baseline in MTSS is significantly better for Upadacitinib 15 milligram and Upadacitinib 30 milligram, but not UPA 7.5 in Japanese population.
Right.
So that,
but it was interesting that there wasn't a big difference at ACR 20 at week 12 between the UPA doses.
That's right. However, the joint destruction is better for UPA 15 and 30, but not 7.5.
Right.
It's interesting. Yeah.
It is interesting. So everybody always says, talks about the DAS score. What were the outcomes with the DAS?
Mm-hmm. Yes, in this trial, the secondary endpoint included the proportion of low disease activity and remission defined by DAS28-CRP, SDI, or CDI. And when you looked at the DAS28-CRP low disease activity, MTX showed 80%, whereas the UPA 7.5, 69, and UPA 15, 78, UPA 30, 79. So that the UPA 7.5, 15, and 30, all UPA monotherapy showed superior compared to MTX mono. That is not only for LDA by DAS28, it is also true for DAS remission, SDI LDA remission, CDI LDA remission. All of the LDA and remission status by DAS, SDI, CDI, Upadacitinib monotherapy showed superior result compared to MTX, even with 7.5 milligram.
And you saw a clear dose response then across the doses, 7.5, 15, and 30. So that's an interesting finding. And we should always look at CDI in patients on JAKs because of the effect on CRP and ESR.
That's
very
right.
Good. So a clear dose response across them. But 7.5 wasn't too bad.
Yeah, I think so.
Excellent. And what about safety? Because that's one of the biggest issues, and we worry about zoster in the Japanese population. So what did you see in safety?
So speaking about herpes zoster incidence is lower for 7.5 compared to 15, but there is no big difference between 15 and 30 in Japanese population.
Right.
So when you looked at the opportunistic infection, again, the 7.5, the lowest, the 15, a middle, and 30, the higher for opportunistic infection.
So dose response, even for safety. We always look at anemia as a way of loss of JAK cell activity. Did you see some anemia with the 30 milligram dose?
Yes, the anemia, the grade 3, more than a grade 3 anemia, the level of hemoglobin is much more lower for Upadacitinib 30. That is 12% compared to 7% for Upadacitinib 15. That is a significantly higher anemia for UPA 30.
So again, that just suggests that even though these drugs are selective, if you push the dose, perhaps you start losing selectivity. Very interesting.
Maybe,
but no real MACE or VTE signal in a very short trial with small numbers, hey?
Yes, that is lucky for Japanese patients. The BMI is lower, and the MACE incidence in the general population is lower than Western world. As a result, there is no big difference for MACE in Japanese population.
What about VTE that we all worry about?
DTE, no, nothing. So
Excellent.
that is okay for Japanese RA particularly.
Perfect. So we saw a dose response for efficacy. We saw a dose response for effect on radiological prevention of progression, and even a dose response for safety. So what doses is going to be used in Japan, do you think? 7.5 or 15?
Not only clinical response, but also the inhibition of joint destruction. The 50 milligram is at the best dose,
right?
Particularly compared to when we consider about the clinical response, that is not so big difference between 7.5 and 15 for a DAS or CDAI, low disease activity remission rate. The numerically, the 15 is better than 7.5. As a result, the 15 may be the optimal, the best dose.
It's a nice blend of safety and efficacy. Very good. So how do you think the Japanese population study of Select Early compares to the international results? Very similar or different?
Yeah, I think it's similar, but the clinical response is that is always the higher for Japanese patients compared to the Western world. For example, the ACR 2050-70 or does a CDAI LDA or remission rate is 10% higher for Japanese RA.
Right. And
however, the joint destruction is much more worse for Japanese RA. It's very interesting.
You did pick a very at-risk population with
That's right.
Lots of CRP, baseline erosion, seropositivity. So that might explain that. So similar results across the board, some nice safety data, even though short-term study. Any take-home messages for the practicing clinician from your study?
If you can consider some comorbidity, such as the renal dysfunction or liver dysfunction, that is the major pathway to excrete the JAK inhibitors. Such a patient with some comorbidities, you can reduce the dose of Upadacitinib 15 to 7.5. So even though you use the lower dose of Upadacitinib, the clinical efficacy is comparable to 15 milligram. However, you should be careful about the progression of joint destruction. There is a message. The side effect is maybe a herpes zoster or opportunistic infection is lower for 7.5 compared to 15. That is the feedback from Japanese sub-analysis for a Select Early.
Excellent. Now, if things were all cost neutral, so the cost wasn't in this, and in the future, do you think you would start your patients on a JAK like UPA or on methotrexate like the guidelines say, if you didn't have to worry about cost?
Yeah, if we can neglect the cost issue, then maybe the efficacy point of view, the JAK inhibitor mono is a very good option, particularly for achieving remission or at least low disease activity at week 24. That is the T2T strategy.
So that sounds very interesting and promising for the future when some of these drugs will be off patent, not too far into the future, and we might have new choices not driven by cost.
Yeah,
so we do thank you so much for your time. We know how busy you are. This has been the CSF Author Interview Podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcasts from. Please tell a friend about the podcast to listen in and let us know what you think. We always love some feedback. So thank you, Professor Tom. That's been very, very helpful, and we appreciate your time. Thank you.
Thank you very much. Thank you very much, Peter Nash. Thank you.
Sayonara. Thank you.